Good morning, everyone, and welcome. I'm Dr. Asim Hassin, and I'm glad you're here today. We'll be discussing toxicology emergencies, focusing specifically on organophosphorus poisoning. Over the next few slides, we'll cover the essentials, what causes it, how to recognize it, and the best ways to manage these emergencies. Let's get started and explore this important topic together. Let's look at this case of a 48-year-old farmer who presents with confusion, excessive oral secretions, diarrhea, pinpoint pupils, and wheezing. Notice that his clothes smell like pesticides. The key here is to identify which toxidrome best explains these symptoms. The symptoms like salivation, diarrhea, and pinpoint pupils are classic signs of cholinergic excess. When someone is exposed to pesticides, especially organophosphates or carbamates, they inhibit acetylcholinesterase. This leads to an accumulation of acetylcholine, causing overstimulation of cholinergic receptors. So, in this scenario, the toxidrome that best fits is cholinergic. It's important to recognize these signs quickly because the management differs significantly from other toxidromes. This highlights why understanding the specific features of each toxidrome is essential for accurate diagnosis and effective treatment. The correct answer here is C, and I want to explain why. Organophosphates are known to cause a specific type of poisoning called cholinergic toxidrome. This occurs because they inhibit the enzyme acetylcholinesterase, leading to an accumulation of acetylcholine in the nervous system. As a result, you get overstimulation of cholinergic receptors throughout the body. This overstimulation manifests as the classic DUMBBELSS symptoms: diarrhea, urination, meiosis, bronchoria, bradycardia, emesis, lacrimation, sweating, and salivation. Recognizing this pattern is crucial because it helps us identify cholinergic poisoning quickly and start the appropriate treatment. So, understanding that organophosphates cause this specific toxidrome really ties into the bigger picture of managing poisoning cases effectively. Let's take a look at this question about the primary mechanism of toxicity in organophosphorus poisoning. As you can see, the options are sodium channel blockade, acetylcholinesterase inhibition, GABA receptor antagonism, NMDA receptor activation, and beta-adrenergic stimulation. Now, the key point here is that organophosphorus compounds primarily target the nervous system by disrupting normal neurotransmitter function. Specifically, they inhibit acetylcholinesterase, the enzyme responsible for breaking down acetylcholine in the synaptic cleft. This inhibition leads to an accumulation of acetylcholine, resulting in overstimulation of cholinergic receptors throughout the body. This overstimulation causes a range of symptoms, from muscle twitching and weakness to more severe effects like respiratory distress. So, when considering the options, it's clear that the most accurate answer is B, acetylcholinesterase inhibition. Understanding this mechanism helps us grasp why organophosphorus poisoning presents with such a characteristic clinical picture, emphasizing the importance of targeting this pathway in treatment. All right, let's take a closer look at this question. The correct answer here is B, and I want to explain why. Organophosphates are a type of chemical that irreversibly inhibit the enzyme acetylcholinesterase. This enzyme's job is to break down acetylcholine in the nervous system. When it's inhibited, acetylcholine isn't broken down as it normally would be. As a result, there's an excess of acetylcholine present at both muscarinic and nicotinic receptors. This excess leads to overstimulation of these receptors, which can cause a variety of clinical effects. This mechanism is important to understand because it underpins how organophosphate poisoning occurs and how it can be treated. So, the key takeaway here is that organophosphates cause a buildup of acetylcholine by irreversibly inhibiting acetylcholinesterase, leading to widespread overstimulation of cholinergic receptors. This concept ties into the overall theme of toxicology and the mechanisms of different poisonings. All right, let's look at this scenario. We have a patient arriving in severe respiratory distress with copious secretions. Now, this is a critical situation, and our first priority is to address the airway and breathing issues immediately. The question is, what is the most urgent intervention here? When dealing with copious secretions and severe respiratory distress, the key is to quickly stabilize the airway and ensure the patient can breathe effectively. Among the options provided, the most appropriate initial step is to administer benzodiazepines if there's an associated seizure or agitation, but that's not our primary concern here. If we look at the choices, activated charcoal, pralidoxime, atropine, naloxone, and benzodiazepines, what stands out? In this case, since the patient has copious secretions, we might be dealing with poisoning that causes excessive secretions, such as organophosphate poisoning. In such cases, atropine administration is crucial because it helps dry up the secretions and improve breathing. It's important to recognize that, while other options have their roles, the most immediate intervention to manage copious secretions and respiratory distress is atropine. This highlights a broader theme in emergency management, identifying the most life-threatening issue first and acting swiftly to stabilize the patient. Correct answer is A. Now, let's talk about why that's the right choice. Atropine is considered the first line and the most life-saving medication in certain emergency situations. Specifically, it's essential for treating bronchoria, bronchospasm, and bradycardia. When we say bronchoria, we're referring to excessive bronchial secretions, which can severely impair breathing. Atropine helps reduce those secretions, easing breathing difficulties. For bronchospasm, which is the narrowing of the airways often seen in conditions like asthma or an allergic reaction, atropine can help relax those muscles. And most critically, in cases of bradycardia, where the heart rate drops too low, atropine acts quickly to increase the heart rate and stabilize the patient. So, in summary, atropine's role as a first-line agent in these situations underscores its importance in emergency medicine, especially when rapid intervention is needed to save lives. All right, let's look at this question about pralidoxime, also known as 2-PAM. The question asks, which statement about 2-PAM is correct? Now, as we go through the options, it's important to remember that pralidoxime is primarily used as an antidote for organophosphate poisoning. Its main role is to reactivate acetylcholinesterase that has been inhibited by these organophosphates. So, starting with option A, it treats muscarinic symptoms only. That's not quite right because pralidoxime actually addresses nicotinic symptoms as well by reactivating the enzyme. Moving to option B, it treats nicotinic symptoms only. That's also incorrect for the same reason. It can impact both types of symptoms. Option C states that it's contraindicated in seizures. While seizures are a concern in poisoning cases, pralidoxime itself isn't contraindicated in seizures, but it's important to use it carefully because it can sometimes cause side effects. So, this statement is not entirely accurate. Now, the most critical point is option D. It reactivates acetylcholinesterase if given early. This is a key concept. The effectiveness of pralidoxime depends on early administration before the enzyme ages, which leads us to option E. Option E claims that pralidoxime is effective even after enzyme aging. But actually, once aging occurs, pralidoxime cannot reactivate the enzyme, so this statement is false. Putting it all together, the correct answer is that pralidoxime reactivates acetylcholinesterase if given early, before aging sets in. This highlights the importance of prompt treatment in organophosphate poisoning cases, which aligns with our overall theme of timely intervention in toxicology management. All right, let's look at the correct answer here, which is D. Pralidoxime is a crucial part of the treatment because it reactivates acetylcholinesterase. Now, this enzyme is responsible for breaking down acetylcholine, so when it's inhibited by nerve agents or pesticides, acetylcholine builds up and causes the symptoms we're trying to manage. A key point is that pralidoxime works best before the aging process occurs. Aging is when the enzyme inhibitor complex becomes irreversible, making treatment less effective. By giving pralidoxime early, we can reverse the inhibition, improving muscle weakness and helping to prevent respiratory failure. These are the critical symptoms that can become life-threatening if not addressed promptly. So overall, pralidoxime plays an essential role in restoring normal nerve function and improving patient outcomes when administered at the right time. All right, let's focus on this question about severe organophosphate poisoning. The question asks, what is the most common cause of death in these cases? Now, looking at the options, we have ventricular arrhythmia, renal failure, respiratory failure, hepatic failure, and cerebral edema. In cases of severe organophosphate poisoning, the primary issue isn't usually related to the heart directly, so ventricular arrhythmias are less common as the initial cause of death. Most often, the critical problem is respiratory failure. This happens because organophosphates inhibit acetylcholinesterase, leading to an excessive accumulation of acetylcholine. This causes widespread stimulation of muscarinic receptors, resulting in bronchoria, bronchospasm, and muscle weakness, all of which impair breathing. If not promptly managed with supportive care and antidotes like atropine, respiratory failure quickly becomes life-threatening. So, the most common cause of death here is respiratory failure. This highlights the importance of airway management and prompt treatment in these poisoning cases. The correct answer here is C, and let me explain why. Typically, death in these cases occurs due to respiratory failure. This happens because of a combination of factors like bronchoria, which is excessive mucus production in the airways, bronchospasm, meaning the tightening of the airway muscles, and paralysis of the respiratory muscles themselves. All of these components work together to impair breathing significantly. It's important to understand that these mechanisms are central to the pathophysiology we're discussing and highlight how critical respiratory support can be in managing such cases. So, when you're thinking about the causes of respiratory failure in this context, focus on these key factors: bronchoria, bronchospasm, and muscle paralysis, that ultimately lead to respiratory compromise and, unfortunately, death if not managed promptly. Let's take a closer look at the pathophysiology of organophosphorus poisoning. The core issue here is the irreversible inhibition of acetylcholinesterase, or, when this enzyme is blocked, it can't break down acetylcholine effectively. As a result, acetylcholine accumulates at various sites in the body. This excess acetylcholine then causes overstimulation of receptors. On muscarinic receptors, this leads to symptoms like salivation, lacrimation, urination, diarrhea, gastrointestinal distress, and emesis, often summarized as sludge. At nicotinic receptors, we see effects such as muscle twitching, weakness, and even paralysis in severe cases. In the central nervous system, the excess acetylcholine can cause confusion, agitation, seizures, and respiratory depression. All these changes stem from the same fundamental problem: the inability to regulate acetylcholine levels due to a CHE inhibition. This is what makes organophosphorus poisoning so dangerous and requires prompt recognition and treatment. Remember, the key here is that the inhibition is irreversible, meaning the body needs to synthesize new CHE to restore normal function, which takes time. Let's take a closer look at the clinical features associated with organophosphorus poisoning, often remembered by the mnemonic DUMBBLSS. First, we see diarrhea and urination, which indicate increased secretions and bodily functions going into overdrive. Next is miosis, or pinpoint pupils, a common sign due to the overstimulation of the parasympathetic nervous system. We also observe bronchoria and bronchospasm, meaning excessive mucus production and constriction of the airways, leading to breathing difficulties. Bradycardia is another key feature, a slowing of the heart rate caused by increased parasympathetic activity. Emesis, or vomiting, is also typical, reflecting gastrointestinal hyperactivity. Lacrimation, or tearing, along with sweating and salivation, are signs of autonomic overdrive, showing how the nervous system is overly stimulated. All these features together highlight the cholinergic crisis caused by organophosphorus compounds, which inhibit acetylcholinesterase, leading to an accumulation of acetylcholine. Understanding these clinical signs is crucial for early recognition and management of poisoning cases. They connect directly to the overall theme of how organophosphates disrupt normal nervous system functions, causing widespread parasympathetic effects. Now, let's talk about the management priorities in the ICU when dealing with organophosphorus poisoning. First and foremost, securing the airway and ensuring adequate oxygenation is critical. Organophosphates can cause respiratory compromise, so we need to act swiftly to protect the airway and support breathing. Next, we use atropine, titrating the dose until the secretions dry up. This helps relieve bronchoria and bronchospasm, improving respiratory function. It's important to adjust the dose carefully based on the patient's response. Early administration of pralidoxime, or 2-PAM, is also essential. It reactivates acetylcholinesterase, helping to reverse the toxic effects of the poison. The sooner we give it, the better the outcome. If the patient develops seizures, benzodiazepines are the go-to treatment. They help control the seizure activity and prevent further neurological damage. Finally, decontamination is a key step, removing contaminated clothing and washing the skin thoroughly to prevent further absorption of the toxin. All these steps are interconnected and form the core of effective management in these cases, emphasizing early intervention and supportive care to improve the patient's chances of recovery. Let's go over some important ICU pearls related to organophosphorus poisoning. First, atropine is primarily used to dry secretions, but it's a common misconception that it affects pupillary size. So remember, atropine's main role here is to reduce secretions, not to dilate pupils. Next, pralidoxime plays a crucial role in preventing neuromuscular weakness by reactivating cholinesterase enzymes that have been inhibited. However, timing is everything. If treatment is delayed and aging of the enzyme complex occurs, then administering pralidoxime becomes much less effective. It's also vital to always protect our staff from secondary exposure. Organophosphates are highly toxic, so proper protective measures are non-negotiable. These points highlight how critical prompt, appropriate management is in these cases. Understanding these nuances helps us improve patient outcomes and keep everyone safe. Thank you so much for your time and attention today. I truly appreciate your engagement and interest in the topics we've covered. Remember, the key points we've discussed are all about understanding the importance of insert main theme, applying the strategies effectively, and recognizing how these concepts can impact your work or organization positively. I hope this presentation has provided you with valuable insights and practical takeaways. If you have any questions or want to discuss further, please feel free to reach out. Thanks again for being such a wonderful audience.